All right. Well, I'll go first here. Since let's see here. So let me start with this case, and give me a second here. And you should see a Röntgengram or Röntgen. All right. So this is an elderly lady who has a long-standing history of rheumatoid arthritis and has these known nodules, which at some point someone decided to biopsy, even though they've been slowly growing for years. And these are indeed rheumatoid nodules. But what's interesting about this case is she presented last month with chest pain, and she's had as you can see, she's had a stent valve placed. And she presented with this pneumothorax, pneumomediastinum, and lots of subcutaneous gas. You should see a CT now. This is her CT, and you can see it got worse. And I think what's cool about this, because I'd never seen this happen before, you can see these ugly looking nodules, very characteristic of these rheumatoid nodules. We see them with sort of these, they get these bubbles of gas in them and often look like lung cancers. But interesting, I went back to some of our old radiographs, and these sort of all became this big confluent mass in this right lower lobe. I'm sorry, in the middle lobe, but in the right lung, it's just this big confluent rheumatoid nodule. And presumably this is where this air leak is coming from, but it could be any of these. But the problem with her was management is trying to figure out how to get her lung to come back up, because these, they're necrotic nodules. So one of them ruptured into the pleural space, and then it tracked back along into the mediastinum. But I'd never seen a case of rheumatoid nodules cause pneumothorax, pneumomediastinum. It's just that these are got big enough over time. And here's one. They almost look like squamous cell nets, the sort of spiculated appearance and everything. So just a bizarre case. Any one of these was the one that who knows which one ruptured. But eventually they were able to get her lungs back up after a while, but it sure took some time. And I'm sure it's going to happen again. So you have to question, do you try a pleurodesis or something? And it's bound to happen on the other side. And then for David, there's a nice.
I'm sorry, have you seen them be as peripheral as that big one before?
Yes, I have. I think I've shown a couple cases, and I think Jonathan showed one years ago where they were more posterior, more in the lower lobes, but they were often subpleural. And, these are so big. And then this is for you too. This is just a nice example of a pseudopneumothorax where you see extrapleural air, gas tracking along in the extrapleural tissues here. And you could put on a coronal.
Cool.
Yeah, because
Jeff, this reminds me.
Yeah, there it is.
We had a case at the VA here that is almost identical to this, and I had questioned necrobiotic nodules. It wasn't this extensive subcutaneous emphysema, but there was a pneumothorax.
Yeah.
And they had biopsied it somewhere and gotten necrosis, and we're thinking it was toxy or something, but he didn't have rheumatoid arthritis. But I need to find that case because it looks awfully similar to this with these big kind of broad-based nodules.
Interesting with her, though, this whole rheumatoid thing, we did a RSNA thing on this past year, but, there's a lot of literature on the whole etiology of it, and it's and I buy into this, that seropositive RA and seronegative RA are two very different diseases, and seropositive RA really is a lung disease where these autoantibodies form with the cyclical citrullinated proteins, and that may or may not cross-react with the synovium, because we see a lot of people who have RA who have really no joint disease but have lung manifestations. And I dug through this lady's chart and I couldn't find any good x-rays that showed erosions or narrowing. She predominantly had lung disease. So it's interesting. And so you wonder, you're saying that VA patient didn't have ROA. Well, maybe they did, and they just didn't have bone disease.
Right, they just hadn't been diagnosed.
Right.
It's kind of like some of the interstitial lung disease patients with their undifferentiated connective tissue disease that hasn't been discovered yet.
Right. Okay, this was a nice case. This was just a trauma, but one of my colleagues I thought made a nice observation. You can see this patient, and I think it was a motor vehicle crash. You can see there's a perisplenic hematoma. But what's kind of interesting was, and this is another David Godwin special, was the observation about the diaphragm, and I think it was right up in here, is this sort of this thickening of the diaphragm. There's a little hemothorax and a bunch of rib fractures, and so we postulated that this was a diaphragmatic hematoma, because there wasn't really a defect in it, but the diaphragm was focally thickened, and I think I can put it on a coronal. And you can see it right in here. I don't know. You guys buy that? An intramuscular hematoma, because it's confined by the, it's got a sharp interface on the inferior surface between the fat and the spleen, and it's got a sharp interface on the sort of the pleural surface here. So, focal thickening of the diaphragm as opposed to a defect.
That's curious.
You work for me.
And it's pretty dense too. So yeah, I thought that was a nice pick, really nice observation, and kind of an interesting thing. And we've seen another one too. So it's one area now I'm paying a little bit more attention to is intramuscular hematomas, and they just manage them conservatively. All right, this is a cool case, and I'm very curious what you guys think. This was a consult to me, and I think everyone in our section has looked at this in about 5 different subspecialties. Let me show you some images. So this is a youngish man who came in. You should see a portable radiograph. Came in with dyspnea and hypoxia, and you can see he's got big pulmonary arteries and sort of not normal looking lungs. It looks like a generous right atrium. This was back in February. This is another CT, a better radiograph of PA and lateral, but clearly has large pulmonary arteries. Here's the lateral. You see there's a left pulmonary artery aneurysm. The right PA looks big. And he's got 2 contrast-enhanced CTs. So this is the first one. And they're about 2 weeks apart. So you can see he's got some lymph node enlargement, and then this really crazy-looking pulmonary arteries. There's filling defects. There's calcium. They're dilated. There's Travis. There's a flow artifact for you right there. And then he had in the lungs, he's got this kind of peripheral ground glass, a little bit of consolidation, kind of confined by the fissure, and just a background of ground glass and some mosaic attenuation. So, and he's got pulmonary hypertension, and he's got right heart enlargement, he's got right atrial enlargement, he's got a little hypertrophy there. And then on the follow-up radiograph, a couple things are interesting. I think first thing is that area of what looked like ground glass, which I would call hemorrhage at the time, looks like it's sort of evolving into an organizing infarct. And now he's developing something on the other side. So when I first looked at this, it reminded me of one case that I'd seen many years ago, and I may or may not have shown it to you guys because it was before I was at UW, but I can show it next time, of Behçet disease, where they get sort of in situ thrombus, aneurysms. He's male, but without knowing anything about him, as one possibility, he has he does not meet any criteria for Behçet's, according to our rheumatologist. So then I, of course, threw out Hugh Stovin as a possibility. He has no other manifestations. So I guess my question is would you guys be happy just calling this CTEPH and he's just throwing infarcts and more clot and this has clearly been here? Or do you think there's more going on than just in situ?
No, I think he's got a huge secundum ASD, doesn't? I mean, it looks like there's nothing in the interatrial septum there.
Yeah.
Scroll down.
Hold on a second. My phone's ringing.
Yeah, it looks as if these arteries were pre-dilated by long-standing pulmonary hypertension and then secondary thrombosis as the flow decreased.
Sorry about that.
With progressive pulmonary hypertension.
Can you guys hear me now?
Yeah. I think this is atherosclerotic calcification and in situ thrombus in the PAs. Can you scroll down to the interatrial septum? Because it looked like there was a huge secundum ASD.
You think right here?
I'm not seeing your screen anymore.
He has a functional PFO. That's what the pulmonologist told me. So I think he's decompressed.
Jeff, your screen is frozen.
Oh, hold on. Let's try this. You see it now? How about now?
Not scrolling. Okay.
Can you see now?
Yes.
Yeah. Yeah, I think he has a functional PFO because I think you could see a flow artifact right there coming across.
They've done an echo?
Uh-huh.
I mean, I've seen. Can you show the other case again? The one that had the better contrast bolus?
Sure. Yeah, I think there's this.
I think there's more than a PFO there. You just don't. I mean, this looks like a typical. Look how much contrast is just swirling around in the left atrium, even in there, Jeff.
Okay.
I vote group 1 pulmonary arterial hypertension from a shunt.
Okay.
And that would explain the calcification too.
Right.
And that was what I was taught, was that that when you have calcification, like think, shunt
Right.
for long-standing pulmonary hypertension before you think like calcified thrombus.
Okay.
Yeah, and when the pulmonary arteries get to be this large, it usually there was a pre-existing volume overload from a left to right shunt to get pulmonary arteries of this caliber in general. So that really does, I think, support the idea that there was that this is Eisenmenger's. And then as the flow decreases in these pulmonary arteries, there's more and more thrombosis forming. When the flow is really brisk and the pulmonary hypertension hasn't taken hold, there's a lot of flow and you don't settle out the platelets. But once you start to get pulmonary hypertension, reduce the flow, then you get the in situ thrombus.
Mm-hmm. It's very interesting. All right. Well, maybe we'll have them go back and look at that echo again. Yeah, because he had no other manifestations. It's interesting because we showed it around our group and everyone came out with the Behçet type vasculitis, just given how big they were, and it looked like in situ thrombus, but that's not panning out clinically because he was quite ill, but he's doing better. And then the other thing they get with Hugh Stoven is intracardiac thrombus, which he does not have. Okay.
Hugh Stoven is just a subset of Behçet's, right?
Pretty much Behçet's without the skin and the ulcers and this more peripheral stuff. All right, here's another case. I'm curious, and Howard, I think you'll really like this one. This is a patient who has cirrhosis, and actually it kind of has two different things, and also has a monoclonal gammopathy. It's really not declared itself to be anything else, but clearly there's something going on with the plasma cells. Patient's never smoker, and you can see these weird, bizarre, I guess that's redundant, cysts. Some of them are very subpleural and almost confluent here. It's kind of interesting. And then some of them are clearly very perivascular. And then just for fun, as I mentioned, this patient does have cirrhosis. They also clinically have hepatopulmonary syndrome, and I'll make this a little bigger for everyone. And so if you look at these vessels, they're not normal. They're sort of they're kind of beaded, and they're going all the way out to the surface. They're a little telangiectatic, like you see sometimes in these people. So, but I was asked about the cystic lung disease, and they're quite extensive. But given that plasma cell issue, that gammopathy, I suggested maybe this is either a variant of LIP that's purely cystic, or a light chain deposition, or something along that amyloid spectrum. I don't know if you guys have seen any. I've never seen LIP look this extensive and this confluent of cystic stuff in the periphery.
Yeah, I agree.
Some of those cystic spaces centrally, I think, I perceive as actually representing dilated bronchi.
Okay.
Do you get the same impression? You scroll back and forth, and you look at the spaces of the bronchovascular bundles up and down, and higher up as well.
Yeah, but
are those connected?
For example,
or not?
Perivenous. I think the problem is there's
keep going up. It's actually like it's hard to say.
Yeah, I don't know.
I might have to scroll around.
I thought the airways were fairly normal for the most part.
Actually, I can't tell. I would have to look at it some more. But it's really how much cystic disease and how much is subpleural. That's really interesting.
It's just bizarre. But I love the telangiectasias. I thought those were kind of cool. And you can see all these little guys going out to the periphery. So, yeah, it's just a really bizarre case. I mean, the cirrhosis is the big issue. And then I'll just do this last one real quickly.
Jeff, what is the cirrhosis from? Do they know?
No, I don't know.
Okay.
I don't know that.
It's not IgG4 or something?
I'm sorry?
What did you say, David?
Are you thinking IgG4?
Well, sometimes like patients with familial pulmonary fibrosis will have cirrhosis too, related to some underlying genetic defect. But I don't know. I was just trying to see if there was a way to put stuff together.
Yeah, I know. I was trying to put it all together too, but I was having a hard time. But I think
there was a poster exhibit at RSNA last year, which caught my eye because it was a series of cases from some place in Washington, D.C., where they had subpleural cystic disease. And then some of the patients developed very extensive cystic parenchymal disease, but they started off as subpleural cystic disease, even along the fissures. And all of them had weird genetic defects. So they postulate that there's weird genetic determined syndromes that can have cystic lung disease like that. And they mentioned a number of genetic defects that meant nothing to me. Maybe that's something like that. I don't know. But what was curious about this case you just showed was how much subpleural cystic spaces there were too.
Yeah, it was very, very odd. Okay, quickly, this last case is just an interesting case. This patient, actually, this is how they presented. You can see the esophagus is abnormal, full of debris, and then there's this gas here, and then this big collection down here in the right lung. So this was a lung abscess that resulted from a perforated esophageal cancer, which is a less common manifestation of the initial presentation. And this is the esophagram, just a few images, but you can see there's very quickly a leak into that abscess cavity there in the right. So just an interesting case. I don't have a radiograph, unfortunately. That would be nice to have, but I didn't get one. So, all right. Those are my cases. Who'd like to go next?
Jeff, I've got a few.
All right.
Can people see a röntgenogram?
We do.
Okay, this person had ablation for his atrial fibrillation therapy. So during the ablation, they monitor phrenic nerve conductivity, and they suddenly didn't have right phrenic nerve conductivity. So I was unaware that they were monitoring this sort of thing. His right hemidiaphragm was elevated. We don't have much preoperative imaging. He did have an MR scan before he had his cardiac, his left atrial ablation, and that showed some eventration of the right hemidiaphragm, but nothing on the order of this degree of elevation. And that was in bed, which exaggerates the elevation of a weak hemidiaphragm by putting the abdominal weight against it. And here's what he looks like standing up. No, that's not immediately standing up. So yeah, 9-3, this is the day after. So he does have elevation when he's standing up now for PA and lateral views. And the elevation goes all the way back, unlike eventration, where the elevation usually ends posteriorly. So this is consistent with some diaphragm paresis or weakness. And then they follow this along. Here's what he looked like later that month. It's even more exaggerated a couple of weeks later, and you see the elevation of the right hemidiaphragm. Then beginning in December, we get less elevation. Again, it's elevated all the way back, consistent with weakness or paralysis. And this current imaging from this week shows almost restoration of normal diaphragmatic height. So this is evidently a known complication of left atrial ablation. The phrenic nerve is running over part of the left atrium, and they managed to zap it as part of their cryotherapy for his left atrial, atrial arrhythmia. Have you guys seen this complication of ablation before?
No.
No.
So it's just the heat generated by the procedure that actually gets enough of the phrenic nerve to cause a neuropraxia. So just
they were using cryotherapy here, so they actually cooled it, but they managed to damage it. And they said they had conductivity below the site. So I don't know how they do this sophisticated phrenic nerve monitoring, but they said that they lost it at this site, but below that the phrenic nerve was working, so it was consistent with an injury. And they modified their procedure from then on, and they were aware of this at the time that it happened. So the other complication that I've heard about is that you can create a fistula to the esophagus. I think somebody showed a case of that.
Yeah.
Yeah.
We've shown, yeah, Howard and I have both shown those.
Yeah. I don't recall seeing this that I know of, or I just haven't recognized it. That's really interesting. I'll have to go back and see.
There's a nice article in the January-February issue of Radiographics on the thoracic nerves. So they show where they run, so you can get a sense of why this complication potentially would occur.
Great.
All right.
So let me show you another case here, because I know you're not convinced so far. So here's a mediastinal mass at this location here. Not, I don't think, well, maybe it's visible here on lateral view. And let me see if I can pull up the right CT on this one. So it should be something 218. Yeah. So here's the CT scan on this person. And you can see that this is a cystic appearing mass. It has uniform density in the center, and it measures about 30 Hounsfield units. And it has a bilobed configuration that extends out here into the lung. So I've never seen a cyst in this location with this appearance. The 30 Hounsfield unit attenuation suggests in the right location this could be a bronchogenic cyst, because the mucoid secretions give it higher density than you'd expect for, say, a pericardial cyst, which I have seen this high and even higher. So I didn't know what this was. It doesn't look like a thymic cyst. It's not as watery as the usual thymic cyst, and the location's a bit off for that. And this was resected, and it is indeed a bronchogenic cyst. There was cartilage in the wall of this thing, so it was clearly, and it had nice bronchial mucosa. So it's a bronchogenic cyst. It's bilobed, and it sticks out into the lung. The surgeon said that this was difficult because there were adhesions around it, and it had this funny shape to it. He had to sort of go under vessels to get to it, and removed it with difficulty, and therefore charged more. So he was complaining in his note about how difficult it was and justifying the charges as he went. So this turns out to be a bronchogenic cyst. I've never seen one quite in this location. I've never seen one bilobed.
It's funny looking. Wow, that's interesting.
Okay, and okay, I can pull up my next case here. Say 455. Okay, 239. Okay, this person has an installation of this device here that you can see barely here in the location of the left atrial appendage, and on lateral view you can barely see this metallic thing that looks like an umbrella. This is the Watchman device that's designed to occlude the left atrial appendage in people who have atrial fibrillation and are at risk of forming thrombi there, the sort of thrombus that was shown last week by Travis. And here's what the device looks like here on CT scan. We happen to have CT on this person. And here's this umbrella-like device installed in the left atrial appendage. So this is called Watchman, and the idea is to occlude the left atrial appendage. The surface of this is supposed to endothelialize with time and not be thrombogenic. And I think I might have a picture. Here's what the device looks like. It's this sort of parachute-like thing with a wire strut. And here it shows it's being installed here in the left atrial appendage with this smooth surface against the left atrial body here. And so this is called Watchman here. And this permits some people to go without anticoagulation. So here it is on CT. This CT was done for other reasons. This is actually a case I showed before because of the elevation of the right hemidiaphragm, phrenic nerve paralysis, variously attributed to graft versus host disease and a bunch of other things. This person has so many different medical problems, it's kind of scary. And
Great.
And then this person has this subtle opacification of the right hemithorax with displacement of the mediastinum away, implying that there's some space occupying lesion on the right. This is not just an ordinary lung collapse. And indeed, on CT, it turns out that there really is a problem on that side. There's this very large tumor that is mashing into the mediastinum and even narrowing the airway here at the carina. A very large lesion with some heterogeneity and calcification in it. Huge thing here. So my first thought was something this large was probably going to be a solitary fibrous tumor, and it turns out,
Or maybe an IMT, inflammatory myofibroblastic.
I don't have that much experience with those, and the ones I've seen have been not
That.
this size. So,
Or
any other
sarcoma whenever it gets that big.
Sarcoma.
Okay. Well, the answer is they did this thing with they resected this thing by doing, as if they were doing a lung transplant, they cut across the thorax. They did this clamshell incision to remove this thing. And I think they used, this was a forceps delivery. I mean, this was very large. And it turns out to be a benign schwannoma.
Schwannoma.
Whoa.
So, who would have thunk?
Who would have thunk?
Yeah.
Vessels, necrosis, some calcium.
That is going to be the biggest
Wow.
schwannoma I've ever seen. And was it coming off an intercostal nerve?
It wasn't clear to me where it arose. They had a lot of difficulty getting the thing out. I'll go back and check and see if the surgeon commented on the origin. And then I wanted to show you guys this last case. This person had, this is a HeartMate 2 LVAD in place, and they noticed the person came in because of low pressures, came to the emergency room, and they found that there was a lot of narrowing in the outflow here. And so they placed this stent here. So this is the first, I mentioned this case last week to some people. They stented the efferent limb here of the HeartMate here in order to restore some flow here where there was narrowing. And we have CT on this. There's a lot of motion artifact on this, but here is the opacified lumen of the outflow cannula, and this is the stent within the bigger outflow cannula. And you can see that there's pretty good opacification at the center of this stent, but then as we get close to the attachment, there's some narrowing proximally here, and it doesn't seem to be as well opacified. So there's still some residual obstruction here, but they managed to restore flow quite a bit. I think the sagittal is actually the best way to look up the barrel of this thing. So here is the device here. We're looking up the barrel of it, and you can see that there is lumen at this point as we get away from it, and then as we get close to the device, it's somewhat compromised. So that there's an open channel there, but it's not as wide as we get close to the device. So they successfully stented this person, restored flow. I've never seen this sort of thing. So I'm used to stents in native vessels, but not stents in devices like this. But those guys are unstoppable.
That's really interesting. Now, I showed a case a few years ago. So with the outflow cannula, you have a tube inside of a tube. So that area, that rim of darker attenuation is like the outer tube. And I had one, maybe you guys remember, that it was narrowed, and we thought it was going to be thrombus, but it ended up being debris that was accumulating, between the two tubes, essentially. And it almost looks like this. I wonder if that's what they're stenting to reopen it, to just displacing something that was accumulating outside of the, of the inner lumen. That's really interesting.
I think that's the case. So I'm glad you explained that, because so you're saying at this location, this could be, I think this is the stent, though. Because that end, right, the very bright part is stent. But you're saying that even in the absence of a stent, there's still a tube within a tube? Can you see two lumen? I mean, can you see two walls in that situation? You see what I'm saying? We see two walls here because there's a stent inside.
Right.
So you're saying that normally you wouldn't expect filling all the way out to the edge of this larger...
No, that's correct. Because you often will have a little bit of fluid, that low attenuation material, and it's important not to mistake it for thrombus, because you usually have a little bit of a rim, but this is much more than expected. So I'll see if I can pull up that case.
This is greater than expected back here, you're saying?
Agreed.
Okay. All right. Well, I appreciate that. Yeah. Thank you. Okay. Let's see. There may be one other here. Okay, that was that one. Okay, let me see if I can find it here, Jeff. It's kind of a mess right now, so I'll show it later if there's a chance.
That sounds good to me. All right, Howard or Travis?
I can go
Let
any.
Howard show a couple. Yeah, I'm going to pull up that LVAD case.
All right.
Okay.
So let Howard go ahead.
Okay. So this one is a first for me for sure. And I know I sent this some of the images out to you earlier this year, and then I've waited to see how things evolve since then. So the story here is that this person had a decision was made to biopsy some lymph nodes. So let me just show you the pre-procedure imaging. And someone decided that these lymph nodes needed biopsying because there was a concern about possible sarcoidosis. So I'll just give you a feel for what the lymph nodes look like in the mediastinum, and I will tell you that they went for, in particular, or at least in part, for these lymph nodes here that are adjacent to the left main bronchus in this location. So that was done ostensibly without any problems, and that was done in early December. And the patient came in quite symptomatic here. So now we're going to go to January. And when he's symptomatic, including chest pain, this is what his mediastinum looks like in that location there. So let me just scroll back to where that lymph node is. So this is clearly very abnormal. The process obviously faces that lymph node, and it has ill-defined margins with mediastinal fat, but it's otherwise confined to the left subaortic mediastinum in that location. So there was a question is, what is this? And then initially when I saw this, I'm not sure I had the history of the previous biopsy, but then when we did get the history of a previous biopsy, it was said that, well, because quite a few weeks elapsed between the biopsy and his clinical presentation, that this is probably not related to it. But he was admitted, and then I will show you had a number of CT scans, and the most recent that he had before discharge is this one. So now we have 7 days between the two. And you can see here that he develops pericardial fluid. That subaortic process is no different. There's no circumscribed fluid collection within it. And it's not progressing, but more fluid is accumulating in the pleural space, and he's got pleural effusions. So a clinical diagnosis of mediastinitis complicating that procedure was made, and no organism was cultured from the blood. A biopsy of this was not done, and I think that was reasonable. Never developed something that looked like an abscess. So sure enough, here's a report of mediastinitis and pericarditis after that procedure. And let me show you an image of it, which looks very, very similar to what we have. So here we have some opacity about that particular lymph node. Pericardial fluid develops. So there's one case report. And here is just a report of a series of adverse effects after these kinds of procedures. And if you look at the abstract over here, they don't have images here. But one of the things that is reported is mediastinitis. So let's see, we can see here. Obviously, it's pretty uncommon, but most of them were infectious in origin. And as you can see here, mediastinitis or mediastinal abscess formation has been described. So I think undoubtedly this is what it is, even though some time elapsed, kind of a smoldering infection. But everything fits for that.
So, Howard, what was the diagnosis from the needle biopsy?
He had some granulomas, apparently, so it did reveal some granulomas.
Okay, thank you.
Yep. So I don't know if you've ever seen this. This is certainly my first. And he has been discharged. His chest pain didn't get any worse, and he's just been watched. So, really interesting case, I think.
Yeah.
Okay, let me show you this one. Well, actually, let me just go back in time to show you this one. This is one I showed before of a patient with very extensive hemorrhoidosis. So here is more than just alveolar septal. This is just extensive and large opacities in the lungs. We have nodules, but we have large opacities. We have cystic spaces. We just have everything in the lungs. And here's some images of the biopsy. Here is the spectroscopy from the Mayo showing that it's the AL type. And she does have an abnormal clone of plasma cells. They're treating her for that. And I want to show you, just out of interest, a follow-up. This was really obtained for the heart, but I think it's a nice example of the uptake of GADO. So this is delayed enhancement of gadolinium by the amyloid. There's some areas in the central part of this big mass or blob that don't take up the GADO, and I'm not sure exactly what's happening there, but you can see it here. This is with treatment. Somehow maybe there's some liquefaction or some process in there. But otherwise, just shows what protein and GADO do. So that's just sort of a follow-up to a case that I showed before. So here is another patient that I saw the other day.
Was there also amyloid in the heart on that study?
I don't think so. So I'm just showing you a few selected images, but on this particular one, I don't think there was any, I don't think that there was any deposits for sure.
I was just wondering about the left atrium.
I wonder about that, I'm not sure.
Anteriorly on the left atrium too. I don't.
I'm not sure.
What do you guys think? Is that? I'm not any good at this cardiac MRI stuff.
Well, amyloid will affect the atrial walls, and you often have thickening of the interatrial septum and delayed enhancement.
Are we
of the
seeing
left
it?
atrium.
Do you think this qualifies?
I don't know. Keep scrolling down. Can you scroll through the LV? I'm not exactly sure what type of sequence.
I'm not sure either.
What kind of delayed enhanced sequence?
This is some kind of customized delayed enhancement that the folks do here, and I don't have insight into it.
That pseudo is what we're seeing, pseudo enhancement of the left atrial wall, because I'm seeing a white rim in the left atrium.
No. Yeah, I agree. I don't know what with this sequence.
Yeah.
I'm afraid to commit.
Yeah.
Yeah, typical relationship problems, Travis.
So here's another patient. This is kind of interesting. That I thought I had the. Hold on a second. That's really weird. I thought I had the clinical information right up there. I don't yet, but I do have it elsewhere, and I'll put it together. So the history here, this person had some GI symptoms and eventually came to a biopsy which showed duodenal amyloid. And that was also sent to the Mayo, and that's also an AL amyloid protein. So she was diagnosed with gastrointestinal duodenal amyloidosis without renal involvement. So I assume that this is concurrent pulmonary parenchymal nodular amyloid as well. Obviously, there's no need to do a biopsy, but I think given the amyloid and the nodules and the appearance of the nodules, they're all over the place, that this is probably nodular amyloid in the lungs as well. Well, I think that's a very reasonable assumption, but I don't have pathologic proof. There were one or two, like this little tiny guy there, that I thought had some calcium in it, maybe a little bit, but I think this is very consistent with nodular amyloid. So I don't know why the combination, because often one can see nodular amyloid in the lungs without any other amyloid anywhere else usually. But this is a curious combination of GI and presumed nodular amyloid in the lung.
Cool.
So that's really interesting.
Look at all those things.
Yeah.
Days like that. Wow.
Yeah. So I do have the clinical information. I just forgot to put it together into a PDF for you, but I'll send that out. Let me see if I can show one more that might be interesting. I have a lot of interesting ones actually, but I want to show you. Oh yeah, this one. So this is a pretty dramatic case, really dramatic. So let's check this out. So we start in this patient. This person had a whole bunch of organ systems involved. But there you go. Shouldn't be there. So we have these large filling defects consistent with aortic arch, so-called mobile thrombus in the aorta, and then just tremendous pathology in the abdomen. So there's splenic infarction. But just look what happens to the aorta right here. Boom, just occluded pretty much by thrombus. So there's a lot of pathology in vessels, but I was really impressed by that. There's kidney on the right side, there's renal arteries out on the right side, the splenic one, and then this over here. So I don't know why this is happening, but I think this is a described thing. Certainly it's a management dilemma in this particular patient, because the patient has had stroke and other things. They just anticoagulated this patient and hoped for the best.
What was going on with the pancreas? Was that a pancreatic necrosis due to ischemia, or does a patient have a mass that made them? I mean, that looks more like a mass. I wonder if they're prothrombotic because they've got a big pancreatic tail cancer now.
Ooh, let me see. I don't remember even noticing that or going right by it. Oh, now I don't know.
I mean, certainly you can get just spontaneous mobile arch thrombi without an underlying predisposition, but if she has this patient has a cancer, that would certainly be a reason to be, coagulopathic.
Okay.
Well, there's nothing in the arterial supply to the pancreas that suggests that this could be another infarction. It doesn't look that edematous around it. Yeah, maybe there's a mass.
I must admit I went right by that and paying any attention to it, so now I don't.
It looks like the celiac axis, though, occludes. Keep scrolling down. So you've got right. Yeah, keep going down, and then there's is that like what branch is that? Is that?
Oh, that's all from.
That's all the splenic. That's all splenic artery. That's what that is. Okay.
Okay, so the question is, what's going on there? I don't know. Okay, I'll have to try and find out and see what I can find out and see if there are any follow-up exams for that. Oh, yeah. Okay, I don't know. All right, I'll have to get back to you about that. Good observation. I don't think there was anything that I noticed. Oh, there was even emboli in the pulmonary artery. So I wonder if there is a coagulopathy. So let me go back and remind myself. So here, in the middle lobe, here and there, I do have a follow-up. So I'm going to have to get back to you. There were clots there and there. Not just the aorta, but a little bit.
Very interesting.
Right there. Oh, yeah, now I remember it sort of vaguely. So there's pulmonary emboli too. Oh my goodness. Okay, I'll have to get back to you and see what happened to that. Oh, okay. Pretty dramatic. Okay, let me stop there, Travis. This, you've got cases, right?
So, Jeff, could I show my last case quickly?
Sure, we'll do it real quickly. There we go. Alrighty, should be able to show now.
So, speaking of pericardial effusion, I think that would be a consideration for this funny contour here of the mediastinum and accompanying, along with pleural effusions on both sides. But things are never that simple. Okay. Let me show you the CT on this person. Let me show you the CT on this person. And this turns out to be not pericardial, but a big mass here alongside the mediastinum. It's hard to tell where this originates. I mean, it could be from medial pleura. There's accompanying pleural effusion on that side. Very inhomogeneous mass.
Or Yeah. Oof.
Be on the edge of the mediastinum here. I wouldn't assign this to mediastinal origin here. It seems to be coming off the side. So I've never seen anything quite this big before in this location. Almost looks like brain back here. And this was resected, and it was a thymoma, lymphocyte predominant thymoma. So they said it seemed to come off the medial pleura. I was even thinking about fibrous tumor again for a lesion this big and inhomogeneous like this, possibly pleural origin, but thymoma.
Wow.
Impressive. That is
Live and learn.
the biggest thymoma I've ever seen.
Right.
It
Okay.
seems so big, it's hard to know where they start sometimes, oftentimes.
Yeah. The bigger there are, the harder it is, I think.
Pushes everything away and you don't know where it's coming from.
Okay, you guys see this?
Yep.
Okay, so I pulled up two LVAD cases to show quickly. Now these are both HeartMate 2s. And this is a patient who has an infection surrounding the outflow cannula here. And you can see the rim enhancing outside. But David, this is that little rim I was talking about inside, where you can normally see a little bit of material that, and this is part of the bend relief. So it's kind of a tube within a tube here. So it's between the two tubes that you get this little rim. And so that's one that sometimes people will be faked out for thrombus when it's more, conspicuous than that. But that's kind of the normal appearance. Now this is the one that I was talking about, and I know Brent and everybody got fooled on this one, because here, this was from, I guess, 2013, and you can see that you have, all of this low attenuation filling defect, and it's extremely narrowed, and it's confined to that area where you have the bend relief here. And so this is what we thought was going to be thrombus, and they went in and they said that this was all debris, as you can see at the operative findings here, between the bend relief and the graft, so essentially between the two tubes. So I wonder if that's what your case was, that they just put a stent in to kind of push this stuff out of the way.
Yeah, the LVAD in my case had been there since 2012, so it had been there for many, many years, and I think, so I wonder what this grunge that accumulates is then.
Yeah, I remember,
stuff like that.
Yeah, I can't remember if, I think Brent talked to the surgeon back then. I don't remember, but there were two studies 3 days apart, and of course they'd had the patient on anticoagulation. It hadn't changed, which should have been a clue that it wasn't all thrombus.
Mm-hmm.
But yeah, this was clearly more than normal. All right, let me show this. I think I'm only going to have time to show one, but this is a pretty cool case. So this is a patient. I'll show you the radiograph first. And this is I think he's 37 years old, something in his 30s. And you can see he's got this cavitary lesion in his left upper lobe. There's an air fluid level. It's got a wall to it. It's not the biggest, it's not the thickest wall. Certainly younger than you would expect for cancer, although this could be a squamous cell carcinoma. But I'm showing the radiograph first just because I think it gives it's a good place to start, even though I'm going to work backwards here. Let's see. So he presented originally with about 2 years of worsening left upper extremity pain and paresthesias, and they did this angiogram, and you can see that his left subclavian artery is severely narrowed here, and it's curious that you have this, in proximity to this is that cavity in his left upper lobe. And when you look at the axial images here, you can see that this thing in his lung and in his pleura, because it's clearly in his left upper lobe, extends outside of the apex and essentially encases the left subclavian artery. And he had some brachial plexus symptoms too. This was affecting his brachial plexus. But I think it's cool to look in his lung and you see all of these little, little centrilobular and some tree and bud nodules throughout his lung here. And so the story, anybody want to guess? I can.
TB.
TB or Coxie.
Yeah, TB or Coxie. And he had valley fever. He's from the Central Valley. He had been treated with antibiotics a few years ago, before all these symptoms started. And then this has happened over the last couple of years. But I'll show this because they did an arteriogram, and it's a nice review of the anatomy, which I'll pull up side by side here. And you'll see that this, by this point, his oh gosh, why does it keep doing that? By this point, his subclavian artery is just a little thread and then reconstitutes distally. But you can see his vertebral artery, his internal mammary, and then his thyrocervical trunk right here, which you can see, which is this big one. And then if we went more distally, you'd see the costocervical trunk, but we can't really see it because I think it's occluded there. But they did take him to surgery recently. Here's the subsequent chest CT, and you can see the same thing. So this is just a big abscess cavity in his lung that has necessitated out through his apex, occluded his subclavian artery, and affected his brachial plexus.
Jeez.
And it's all from cocci. So the surgeons, they mention cancer in here. We never mentioned cancer. But you can see, so he originally had chronic valley fever and then has had this progressive symptoms that led to all of this workup. And then the pathology, they did get just acute and chronic inflammation, and then they did find cocci in it. So, and he is Hispanic, and I know, back to David's comment, I think from a couple weeks ago, just about susceptibility to coccidioidomycosis in different groups. So let me, I think there's time to show one more if I can find it. Let's see. Oh, I'm not in my one list here. All right. And this one's really pretty interesting too, because I've never seen this happen like this. But this is a patient who had a sneaky little lung cancer here. This is back in 2014. And, well, sorry, and I guess they had more of it here. There was lymph nodes and a lung cancer here. They ended up undergoing a left upper lobectomy. And let's see, I'll show you. So this is after the left upper lobectomy. You can see there the staple line, there's surgical clips here. There's a little, fluid or something here. And there was a little soft tissue growing into the bronchus. So at one point they did go in and do a biopsy, and it was recurrent cancer at the stump here. And I don't have, unfortunately, all of the cases, but over the course of the next year and a half, this area dilated, and you'll see on this that there's this big necrotic thing right here along the stump, and you can see some soft tissue centrally. And we just thought this was an enlarging necrotic node in the left upper lobe. But what's interesting is, came back a month ago for a PE study, and I read this with my fellow, and you'll see now what happened, which is that this whole thing just decompressed. Oops. And this is the same thing right here, that it just opened up and dehisced, and now there's a big, in addition to the rest of the lung, this is all in the pleural space, I think. So I think it's a bronchopleural fistula from stump dehiscence, a couple years after treatment, which I thought was just kind of interesting, because this thing just kept on growing, and we thought it was maybe a necrotic lymph node that was growing. And I don't know, maybe it was just a necrotic lymph node, but then caused a dehiscence here and a frank communication with the pleural space. But I thought it was really just a bizarre case.
Oh.
And this patient came in symptomatic too, and I think they had some areas of consolidation, probably just from, and some of this ground glass, probably just infection or aspiration from the communication here. So, I don't know. But it's just a very interesting case, because this clearly is in the pleural space surrounding the lung anteriorly here.
Is there still cancer, do people think, or was this just...
No, there is, and they were started on new chemo. They had been irradiated at some point in time, and I don't remember at what point in time the bronch was, but yeah, and my fellow was telling me they had gotten radiation to the hilum here. So whether it's a combination of tumor, radiation, whether there's some infection here too that predisposed it to, but it was just kind of a delayed presentation of a bronchopleural fistula from a stump dehiscence.
Wow.
Wow, that's in.
So, All right. Well,
All right.
I will stop there since we are
That's really
at time.
Yep. Well, thanks everyone.
Yeah, great cases.
Yep.
great. Yeah, thank you.
See you again next week.
Alrighty.
Bye, guys.
Good weekend.
You too.
Bye.
Bye.